Hello everyone, this is Amir again with Daily Hematology Bleeps. Today our topic is Thrombophilia testing. As a hematology registrar, I have received a lot of bleeps from the ED department, from obstetric colleagues, from SDAC, and a lot from the stroke team and neurology team as well. This is that our patient has developed stroke, or the patient has VTE, patient is relatively young or young patient, we want to do thrombophilia screen in this patient, both acquired and the uh, inherited one. Or sometime you will receive a request from your lab that we have received a request for thrombophilia screen from another team. Do you want to go ahead with this, or would you like to authorize it or not? What should we do? So there is a specific guidelines for thermophilia screening now in the British Society of Hematology. This talk is for both the hematology registrars and consultants and for the non-hematology people as well, to know when they should request hemophilia screening in a patient, or at least when they should talk to a hematologist, or if they are not sure, then yes, they have to discuss with the hematology first. Should we request hemophilia screening in this patient or not? So there are two types of thrombophilia. It is inherited or it is acquired one. In young people, we tend to do inherited thrombophilia screen because we think that this patient may have inherited thrombophilia. But the recommendations is that if you have acute clot, arterial or venous, you cannot do inherited thrombophilia screen. You can only do this screen after 3 months of anticoagulation, and only in those patients where you think that it will change the management of your patient. If it is not changing management, then no need to go for thermophilia screening in a patient. So inherited thermophilias, the important one is protein C, S, antithrombin, factor 5 mutations as well. There are many other inherited thermophilias as well. When you have an acute clot, you cannot do testing for inherited thermophilia screen according to the BSH guidelines. If you still have any query about that, better to ring the hematology registrar or hematology consultant on call that this is a young patient, has a arterial or venous clot. Should I go ahead with the thermophilia screening or not, inherited thermophilia screening or not? He or she will clearly advise you that in acute clot, we do not recommend, as per the guideline, the inherited thermophilia testing. Then he will discuss with you guys why you want to do inherited thermophilia screening in this patient. Is this patient a young female who want to have kids in the future or not? First, the hematology doctor will go through you with the patient background. If it is unprovoked, patient will need a lifelong anticoagulation anyway. Okay. So no need to do the inherited hemophilia screening after 3 months of anticoagulation. If a patient has a risk factor which you think has caused VTE in this patient, but at the same time this patient has a uh, family history of the VTE as well, or there is a family background of any inherited thrombophilia in the patient, and this female patient is planning pregnancy in the future as well, then yes, then you can request uh, inherited thrombophilia screen after 3 months, because when she becomes pregnant, the assessment score will be high, and she may need anticoagulation from the beginning of pregnancy. So inherited thermophilia screening always need a discussion with hematology. Bleep the hematology registrar or consultant and say, this is a young patient, arterial clot or venous clot. Uh, would inherited thermophilia screen would be helpful or not? the hematology doctor will go through the patient history to find out if there is any risk factor or not. If it is unprovoked, patient would need lifelong anticoagulation, no need for thrombophilia screening. What would it change? Nothing. But if there is a family history present of, for example, antithrombin deficiency in the patient, then yes, after 3 months, you can check the inherited thrombophilia screen if this female patient is planning pregnancy in the future, because it will change the patient risk assessment, VTE, pregnancy VTE risk assessment category in the patient. Another type of thrombophilias are acquired thrombophilia. And the most common requests that we receive in acquired thrombophilias are the antiphospholipid syndrome related testing. Yes, this is very important, acquired thermophilia, but now there are also BSH, or British Society of Hematology guidelines about antiphospholipid syndrome testing as well. It has three components: lupus anticoagulant, and there are antibodies, anticardiolipin antibodies, and beta glycoprotein and antibodies. So difficult name. So the antibodies testing can be done in acute period, but for lupus anticoagulant, you have to wait again for 3 months. So the patient need to be anticoagulated for 3 months, and if you think that this patient has likely antiphospholipid syndrome, then you can check lupus anticoagulant after 3 months. But there are other indications of lupus screening as well, like unexplained thrombocytopenia in a patient with VTE, unexplained abnormal uh, uh, prothrombin time, high prothrombin time, or APTT timing in a patient with VTE. We can do lupus screen in the patient. The antibodies, not the lupus anticoagulant. Because I mentioned the antibodies for lupus can be tested in acute period, but not the lupus anticoagulant. And then if you have any unprovoked VTE, then you can do lupus screening as well. Because if it is positive, then the initial anticoagulant you can give patient as warfarin. Okay. But you have to confirm lupus testing, the antibodies or the lupus anticoagulant after 12 weeks again. Because the criteria for antiphospholipid syndrome says you should have two positive tests with an interval of 12 weeks. Then if you have thrombosis at unusual site, like cerebral venous sinus thrombosis, or if you have portal vein or splenic vein thrombosis, which include four major veins: splenic vein, um, hepatic vein, mesenteric vein, uh, and another one I forget. But the anatomy of the splenic veins, it includes four major veins. If there are any thrombosis in it, you can send for lupus screening as well. So yes, lupus screening has many indications. You can discuss with the hematology registrar or consultant again if you are not sure. But if you have unexplained VTE, unusual site VTE, VTE with thrombocytopenia, VTE with prolonged PT, APTT, or if the patient has any background of autoimmune disease, especially SLE, then you can send lupus screen for the patient. But there are other acquired hemophilias as well, which, as a non-hematology doctor, you may not be familiar with. This is the job of the hematology doctor or consultant to decide whether they have to send for other type of acquired hemophilia or not. What are other important acquired hemophilia? MPNs, myeloproliferative neoplasm, JAK2 mutation without MPN features or values, and you have paroxysmal nocturnal hemoglobinuria, PNH. So the hematology registrar or consultant should see whether the full blood count is normal or has any abnormalities or not. So if the full blood count shows low hemoglobin, and some of the hemolytic markers are positive as well, then you may be thinking about PNH, to send PNH screen in this patient. You can send it now. There is no time period limitation. If the hemoglobin is high, then you can think about polycythemia rubra, MPN, if there is no clear-cut secondary cause in this patient, reactive cause in this patient. If the platelet count is high, then you can think about ET in this patient. If the white cell count is high, then you can think about other type of MPNs in the patient. But as per the BSH guidelines, British Society of Hematology guidelines, if you have cerebral venous sinus thrombosis or splenic vein thrombosis, and even if the FBC is normal, then you have to send JAK2 mutation to your Hematological Malignancy Diagnostic Service, HMDS, to see if there is any underlying MPN in this patient which is driving this patient thrombosis or not. Usually we send these tests in the patients which have no clear-cut risk factor. This was a little talk about the thrombophilia testing. Hopefully it will be helpful to you guys, to both hematology and non-hematology colleagues. For the ED, neurology, and ASDA colleague, if they have any difficulty in understanding this talk, they should contact the hematology registrar, or they should contact the hematology consultant on call and ask whether this patient need inherited thermophilia testing or not, whether this patient need any acquired thermophilia testing or not, because it will save NHS budget, NHS money, where it can be utilized on other useful things. Thank you very much.